So I'll start my chrono to be in time. It's difficult to put everything that needs to be said about BPSD in some 20 minutes, so I'll go a bit fast. Here are my conflicts of interest.
You can also take a couple minutes longer if you want. That's okay.
Okay. But this program has not received financial support. And this is the usual slide that you get for the CMA program. So today we'll try to focus on distinguishing categories of BPSD and discuss a bit about their characteristics and their impact on patients and their relatives, and describe also the general clinical evaluation process and be able to choose the most appropriate intervention. So the first point while assessing BPSD is trying to describe the specific symptoms. So more and more the literature is trying to focus and distinguish clusters of symptoms, because now science is advancing and we know that there are some different psychopathological mechanisms regarding all those clusters of symptoms, and they may need also specific treatment intervention. So a first cluster of symptoms are affective symptoms with depression, anxiety, euphoria, or irritability. I put little stars where there is some specific criteria, diagnostic criteria. So for depression, you can find that on the literature. Other cluster of symptom is psychosis with delusion and hallucination. Some may also present with neurovegetative symptoms, change in sleeps or appetite. There are also what I like to explain as frontal dysfunction symptoms or frontal syndrome, with repetitive vocalizations or movements, stereotype movement, wandering can also be put in that category. Also disinhibition and impulsivity, disinhibition either verbal or aggressive or sexual, and some also primitive reflexes or behaviors like imitation or utilization or the grasp reflex that are all associated with frontal dysfunction. And now we have also specific diagnostic criteria for apathy and agitation, even though the term agitation might be a very generic term, and one needs to be sure that the other one is understanding what we mean by agitation. But now the diagnostic criteria are talking about clusters of either verbal or motoric excessive activities and aggressive or non-aggressive symptoms. So we know that BPSD will affect almost all people with suffering from Alzheimer's disease and other dementia at some point in their disease. And those symptoms or neuropsychiatric symptoms are associated with faster cognitive and functional decline. They are also associated with an earlier long-term care placement, increased mortality, decreased quality of life, and increased caregiver burden. It is well known that caregivers often suffer from anxiety and depression. They are also associated with increased use of physical and chemical restraints and increased cost in general for the healthcare system. So in order to assess and intervene when faced with BPSD, I just put the little acronym DICE here. DICE for D, describe, I for investigate, C for create, and E for evaluate. So the first letter, describe, which means you need to be specific about understanding what is the specific behavior. Is it anxiety? Is it psychosis? Is it delusion? Is it wandering? And where does it happen? When? With whom? To try to understand if there are some precipitant factors, for example. that will brings you to investigate the possible causes for the symptoms. Is there medical problems? Is there side effects of medication? Could there be some environmental issues that are triggering the behavior, or maybe the caregiver approach? Those are all potential causes. Then one would want to create an intervention, either pharmacological or non-pharmacological, or modifying the environment, and then reevaluate the plan for its efficacy and also for its side effects tolerability. Here's a little table from PIECES. The PIECES framework that can help to identify many causes that could give rise to BPSD. Either I put in yellow the one that I think we need to focus on. So is there some basic needs that are not being answered? Is there medical condition, either pain or delirium? Is there side effects of medication? Is there altered sense that are not being compensated? Are the symptoms related to cognitive changes, like, I don't know if we can say this in English, retrograde dive, plongeon rétrograde, when people goes back in their long-term memory thinking that they are with their children or at work, when this has not been the case for decades, and this is related to memory change. Is there any psychiatric or emotional symptoms or psychiatric past vulnerability that are being expressed at this particular moment of their life? Is there any specific trigger in the environment? Is it too noisy, too hot, or lack of meaningful contact or stimuli, or loss of privacy? And is there any approaches that are not well adjusted to the capacity of the patient and then are triggering some behavior? So then you go to create your intervention plan. We will discuss a bit on different topics of interventions. I need to put emphasis on the fact that guidelines are still continuing to say that we need to rule out underlying medical problems, and also need to use psychosocial interventions prior to using medication. We were just working with Dr. Feldman on the next CCSMH guidelines that hopefully, I think, will get there, be published in 2024. And of course, non-pharmacological interventions are a very first line intervention that should be organized. Why? Well, because there are some BPSD that are not likely to respond to medication, and you'll recognize there the behaviors I've associated with the frontal dysfunctions. So if people are wondering or having some vocally disruptive behaviors or repetitive activity or inappropriate voiding or dressing or eating, then if you prescribe some medication, it will only act as a chemical restraint. So it won't cure any symptoms there, and it's not appropriate to prescribe some chemical restraint for that kind of behavior. Resistiveness of care also should be addressed first by non-pharmacological intervention or by best approaches. The exception being if there is severe aggressivity, then one might think about adding a medication. Symptoms that may respond to medication are anxiety or depressive symptoms, sleep disturbance, manic-like symptoms, delusion, hallucination, severe aggression or agitation, and sexually inappropriate behaviors. So usually we will treat with medication when the behavior are persistent, dangerous, distressing, disturbing, or damaging to the social relationship or to the person per se. Non-pharmacological intervention could be divided in staff education and caregivers psychoeducation. Those are recognized as being very efficient against some BPSD. It means that understanding the way we need to talk or to approach people with dementia, having good visual eye contact, talking calmly, building a very safe space to communicate, basic approaches like this. Then we can teach people to use basic strategies like validating the emotion that the person is living, trying to do some diversion with specific conversation or activities that the person likes in order to get away the attention on the thing that is stressing that person, for example. We can also try to manage the environment, so it will be helpful in some ways. I'll give you some picture a bit further on. And then there are non-pharmacological, more structured intervention that could be created. I'll discuss that a bit further on. So for education, you have some websites that can help a caregiver to understand BPSD, the ways to approach them, etc. There will be also a BPSD toolkit to be published in 2024. There are also some caregivers psychoeducation programs, either at the Alzheimer's Society of Canada, or you have some here in English and French also that you can consult. When we think about environmental intervention, the facts that need to be considered are the visual and auditive stimulation level. One wants to hide unhelpful stimuli, give temporal-spatial orientation cues, and address the fact that the patients need to reside in an environment that looks home-like. So this would look a bit more home-like than big corridors with dead end where people wander, get into the end of the corridor room where the other resident gets aggressive of being intrude all the time. So this is an environment that is a risk for BPSD. Here you have an example of how we can hide unhelpful stimuli, like the elevator door that people who wander or wants to go away will take. If it's camouflage with some pictures, then it will diminish the risk of wanting to go away. Having an outside path to wander safely is also something that could be very worthwhile if possible. And then more structured intervention. There are many types of interventions of that kind. So one needs to be creative, but the things to remind are that those interventions need first to be individualized to the life story and the interest of the person. They should also be utilized strategically to prevent BPSD at problematic time of the day. So let's say a person suffers from sundowning syndrome. If you want to use an intervention, you need to install it, well, at the time where the behavior might need to increase in prevention. And also the intervention needs to be based on residual capacities like long-term memory, procedural memory, affective memory, and sensorial memory, which are preserved a very long time, even when short-term memory is lost. So you have here some categories for specific non-pharmacological intervention, either sensory, like massage, individualized music, multisensory intervention, aromatherapy, social contact or with pets, structured activities, physical activities, or walking outside, the modification of the environment we already discussed, and training also. I've put in yellow the ones that need to be more efficient, and you will see that in the future guidelines. Regarding pharmacological interventions, the indication are for behavior of moderate to severe intensity that poses a health or safety risk for the patients or others, and when the benefits are outweighing the risk. So general principle in geriatric medicine are the same. So you need to start low with the medication, go slow, but sometimes you need to go in order to treat the symptoms. Use one pharmacological agent at a time, check often for side effects, and know that a complete response can take 2 to 6 weeks. Consider changing agents if there is no evidence of efficacy in order to avoid polypharmacy of many inefficient medications, and attempt progressive withdrawal after the patient has been stable for 3 to 6 months at time. So here are the classes of medication used to treat BPSD. We will discuss antipsychotics, antidepressants, anticonvulsants, benzodiazepine, acetylcholinesterase inhibitors, and memantine. First, I want to make a point that a clinician should think first of maybe it will be worthwhile to empirically treat pain, because we know that pain is common underdiagnosed and undertreated in dementia. For example, with people with resistiveness of care, one might think that it may be associated with pain. So sometimes just by adding routine acetaminophen or thinking about topical therapies or add-on neuropathy therapies, that could be helpful to decrease also the agitation. SSRIs may be the first-line treatment for some affective symptoms like irritability, lability, anxiety, depressed moods, etc. They also might be effective in mild psychosis and agitation. They take about 4 to 6 weeks for a clinical response, but one might need to be careful about the risk of those medications, which are QTc augmentation, mostly with citalopram and escitalopram, the risk of hyponatremia in the first month of beginning the medication, and the risk of GI bleeding. Antipsychotics, the indications are severe agitation and aggressiveness or psychotic symptoms, and their efficacy is, well, they have a modest effect compared to placebo. I switch a bit the type of medication. We used to recommend olanzapine, risperidone, aripiprazole, and quetiapine. You might see some changes in the future guidelines, with olanzapine maybe withdrawn and brexpiprazole just added on with the latest paper that just been published. They have an increased efficacy when symptoms are severe. Quetiapine is the most used, but there is a slow titration, and sometimes it's not well tolerated because of sedation and hypotension. So it might take longer to be efficient when people are actively and acutely psychotic or aggressive. You might think about using a more incisive medication. Typical antipsychotics have less favorable side effects profile, so usually we use it only in emergency case or when there is an IM or a subcutaneous need to be given. Why do we restrict the indication to severe symptoms? It's because you know that antipsychotics have many side effects, mostly extrapyramidal symptoms like Parkinsonism, but also akathisia that often can be mistaken for agitation. And we know that about a quarter of people will suffer from tardive dyskinesia after 1 year of treatment. So this is not a light thing to suffer from. They are also associated with cognitive disorders, falls, drowsiness, hypotension, some with anticholinergic symptoms, infection, peripheral edema with risperdal, metabolic syndrome, and weight gain, especially with olanzapine and quetiapine. And they are contraindicated in some disease like Parkinson's disease and Lewy body disease. So one needs to have an informed or at least substitute consent to prescribe those kinds of medication because they are associated with severe risk, increased mortality with an odds ratio of 1.454. So it means like a 2% increase compared to placebo for people with under atypical antipsychotics. There's one study suggesting that prolonged treatment is associated with an increase in mortality risk, and they are associated also with the stroke risk. You see the absolute risk of about 1%. So patients with dementia taking antipsychotics should be followed closely, and the indication should be reassessed regularly. Benzodiazepine, there are no first-line indication for prescribing those medications in dementia. In fact, they have a non-specific sedative and anxiolytic effects. Sorry for that. And they are associated with many side effects: falls, drowsiness, altered consciousness, worsening of cognitive disorder, delirium, maybe also paradoxical disinhibition. If you want to give benzodiazepine to your elderly patient, you should choose short-acting drugs with a metabolic profile favorable to the elderly, like lorazepam or oxazepam, and usually those prescription needs to be on a short-term basis. Cholinesterase inhibitors might prevent BPSD when started in mild to moderate AD. They are possibly efficacious in reducing apathy and irritability also, but they won't be effective for severe agitation and aggressivity. They might also increase frontal symptoms, so usually we don't use them in frontotemporal dementia or frontal presentation of Alzheimer's disease, for example. And there's occasional worsening of BPSD when they are stopped. The exception would be that they are first-line treatment for neuropsychiatric symptoms in Lewy body dementia because they can improve those symptoms. Memantine also may have a possible effect in preventing or treating irritability, agitation, aggressiveness, and psychosis, but there are cases of worsening agitation and hallucination with that medication also. In specific problems, as I've begun to say, in frontotemporal dementia, first-line treatment are mostly SSRIs or trazodone, and memantine and acetylcholinesterase inhibitor can worsen the behaviors. Sometimes one might need to use atypical antipsychotics if there is severe aggressiveness, for example. In Lewy body dementia or Parkinson's disease dementia, the clinician must work with the neurologist or the pharmacist by first trying to wean off medication, anti-Parkinsonian medication that might increase behaviors or confusion, like old anticholinergic agents or COMT inhibitor, then dopamine agonists, to stay in elderly patients with L-DOPA solely, the littlest dose needed to control the motor symptoms. And in those diseases, the first-line treatment will be a cholinesterase inhibitor. Rivastigmine is the one mostly studied, but it's a class effect, so we believe that any one of them would be useful. Typical and atypical antipsychotics are contraindicated, mostly because they are associated with hypersensitivity syndromes, delirium, and severe extrapyramidal effects, except for quetiapine, which has little efficacy demonstrated in double-blind studies, but is often used because of favorable side effects profile. little dose, but again, sedation and hypotension are often limiting. And clozapine for psychosis in Lewy body or Parkinson's disease dementia is the treatment of choice at low dose, but even at low dose, there's a need to close follow-up with weekly blood count and everything. So usually it's a specialized treatment. I've just put here the IPA agitation algorithm. Algorithm in the literature. Again, they put psychosocial care in as first line, and you can for, let's say, sundown, you see the apparition of DORA medication here. Mild moderate agitation, citalopram, and moderate to severe. There you will see the antipsychotic. Carbamazepine is still on the algorithm, but with many side effects and interaction that makes it difficult to prescribe. Prazosin, you see also other medication. So I'll stop there. So there will be a case discussion. Thank you.
That was wonderful. Thank you so much. A wonderful distillation of a complex area. And I think you've given people a very nice skeleton, a tree that they can hang their ornaments on when it comes to BPSD. So thank you so much. We have a few minutes where we can have some questions and answers. I wonder, Jackie, you've asked some interesting question in the chat. I wonder if you can sort of expand on that a little bit for us.
I'm sorry, you want me to read the chat?
No, I'm wondering if Jackie Harkins might be able to unmute herself and see if she can give us a bit of context around the issue.
Hi, yeah, sorry.
Thank you.
Try to get somewhere a little quieter. So I have a background in psychiatric nursing. Interesting to hear about the clozapine there. But I'm now working in hospice in a continuing care setting. So we are very aware of, antipsychotic use, the risks, these kinds of things. But on the nursing side of it, the non-prescribing side of it, where we're actually dealing with and witnessing the behaviors in a 24-hour period, I find that sometimes we really struggle in communicating how severe symptoms might be, even in a hospice population. So for example, I had a recent example where there was a gentleman who was calling out quite a lot overnight, not just the usual, hello, is anyone there, but absolutely screaming because he's quite hard of hearing. Help me, someone do something, these kinds of really distressed calling out type things. And I find that as a nurse, trying to communicate these things sometimes to a prescriber, some prescribers go right away, oh yes, that's not acceptable, we should do something, and then it's up to them what they choose. But other prescribers are very, very hesitant, where they go, well, how bad was it really? Was it really that bad that you need to medicate someone? So I just wondered if there is a better communication tool or way to quantify some of these behaviors, because when we say agitation or calling out or some of these reactive behaviors, some people just have a different understanding of what that might look like. That's kind of where my thoughts are at.
Thanks, Jackie. Marie-Andrée?
Yes, of course, with agitation, you need to use the vocabulary to be specific so everyone understand what you mean. So in that example, you're talking about repetitive screaming, help me, etc. Then when I'm talking about describing, and that gets to the severity point, severity means the frequency, the distress associated with it, the risk posed to the individual and to others. So if you're able to describe the behavior and saying that it arises very often, the patient seems to be in distress when it happens, or he gets aggressive and there's a risk of self-harm or harming others, then you get to the severity point of disclosing the behavior. And then it's always the same process. You need to think, what might cause that behavior. So
Mhm.
is he in delirium? Should we reassess his medical state, the medication he's taking? Is he in pain? Is he psychotic, hearing voices? Is scared? Is he alone, depressed? So you need to first, again, describe, be specific, give that to the clinician, investigate. Because usually in long-term care, the reflex is to call the doctor and say, well, he's screaming, and then antipsychotics are often prescribed.
Now, you see, I have to say, I find that in speaking with physicians, that is, and perhaps it is also a little bit of a stereotype also. I get that from physicians who, they will often say that, oh, well, as soon as there's a trouble, nurse just pick up the phone because it's easier for them. And I feel for me, like, perhaps it is true in some cases, but it is not always true. And that's the barrier that I, in my profession, face. So we have lots of tools that we use to kind of track reactive behavior that involve check marks, and no one actually looks at them. The doctors don't actually look at them. So I'm just wondering, is there something that is recommended to quantify this? So how do you define moderate to severe calling out behavior? So someone is bedridden, or someone is unable to actually pose a physical threat where they're punching or biting or that kind of thing, where we're like, okay, now we actually have to do something because there's a physical threat, as opposed to someone who's showing severe distress, but they can't actually like act on it other than maybe just screaming as loud as they can. I think I find where the trouble comes in, and it really struck me because I happened to be working with a nurse that night who, she just sat there and kind of didn't anything about it. And I looked at her and I said, well, don't you want to go into this man? And she said, oh, well, in long-term care, this is normal. We get this all the time. And I was a bit shocked, like, why is it normal and acceptable for someone to be screaming and in that level of distress?
Yeah.
And the response, and the nurses, and in my experience now, they're like, oh, well, that's normal, that's okay, because they know, well, the doctor's not going to give me any medication, even if they, like, where do we find the balance between these two worlds in a way? But
I think we need to be trained, both professionals and clinicians and doctors, that we need to be able to communicate the description, the frequency, the severity, and also what might be the causes of that, in order to alleviate the suffering of the patient and often of the staff also when there are that kind of behavior. But one cannot, how would I say that? You cannot avoid being able to have a full assessment of what's going on, because otherwise we might not address properly what's going on. So
Thank you. Thanks, Jackie. That's great. And I think you're also highlighting the normalization of distress, which is something which is quite problematic in long-term care, and something that we need to be mindful of as well. So thank you for that. I see, Shelley, you have your hand up.
Hi there. I'm a pharmacist, so that's my background. I'm going to ask about medications, but also it's sort of linking to what Jackie was talking about, that there might be, especially without the language and maybe the assessment skills on the ground and, remote prescriber maybe, that there might be a sense of urgency to treat the symptoms, to do something about it. And then also, like, in the home, I'm thinking community, for sure. There might be with like caregiver distress as well. And so sort of from there, thinking like if there are medications started, I mean, you want to be able to document what's happening. I mean, your charts saying what was the effect and the side effect is great, right? You need to know what we're trying to change. So if there is no response, do you then like taper down that medication that you tapered up and then start another one? Or do you add another one on? That's what's going to happen. And then if there's like a partial response, do you add another medication on?
Mhm. Well, it depends on every situation, but of course, if you've been to a full trial of what you think is an efficacious dosage and there's no response at all, then you need to withdraw the medication in order to avoid sticking with the medication with potential side effect that has no efficacy at all and having some polypharmacy issues at some point. If there is a partial response, it depends. Is it, could you go higher, or you're stuck with side effects that are limiting the increase in dosage? Are we treating depression or psychosis or aggressiveness? It depends on the condition also. Sometimes, like in depression, we use some combination or some add-on. It depends on all this reflection, on all this on the situation that we're facing.
That makes sense. And what I might also ask is about the psychoeducation for caregivers. Maybe is that going to be part of the toolkit that's coming out, or are there already some places to find resources for that?
Claire, do you want to answer about the toolkit? Are you there?
I am here, and it's a good question that I'm taking note of. I don't know the answer. I know that the resources in the toolkit are going through some sort of extensive filtering, and I'm not sure. But I'll certainly ask and can try to find you, Shelley, and let you know.
I can add, Shelley, that the Center for Effective Practice, the CEP, developed a tool a few years ago where there was a guide to use of antipsychotics for prescribers using the approach that Marie-Andrée is suggesting. And then there was an information sheet for a handout for residents and families in long-term care as well. Might be of help from the CEP, be a link on the CEP website.
Great, yep, I know where to find that.
Okay. There's a question around medication that addresses calling out behavior specifically, Marie-Andrée.
Mm-hmm. Well, repetitive screaming is a very difficult behavior to treat. It often is associated with end life issues, so prognostic to survival with that kind of repetitive symptom is a few months, from what I've read in the literature. And usually we try to assess it with some hypotheses. The first one is there any pain that is causing the screaming? And so try to treat it, as I've said, in the algorithm of medication that could be used. Second hypothesis is there some anxiety or depression issues? Then one might try an antidepressant medication in order to alleviate that. Also, we know that putting people in the rear room and isolating them increase usually the behavior. So even though it decreased the risk of other residents being aggressive with this specific patient, it usually increased the behaviors. So non-pharmacological intervention that might be of interest of that resident might need to be tried also. I had another idea with screaming, and I collaborate in a little research with a nurse in long-term care here, and she interviewed the families about what they were thinking were the sense of what they feel the person was expressing with the repetitive screaming. And it was interesting because it would orient the clinician, either is it distress, is it anxiety, depression, is it pain, or is it just like a disc that is turning around repetitively, like some things like that. So
Thank you. Radi, it looks like you asked and answered your own question around dextromethorphan and quinidine and things like that, the things that are down at the bottom end of the swamp end of the algorithm. So the place where I tend not to tread without support from others. Did you want to talk about that, Radhi, at all briefly before we move on?
No, I found it.
Really?
I didn't even, is it new? Is it like brand new? Because I've not even heard of it, this new Dexter.
It's used
And it actually,
in the States mostly. They put together a molecule with both quinidine and dextromethorphan. Sometimes here in Canada, for some creative pharmacists are trying to put
individual
the medication together. There are some serotonergic effect, and quinidine also, I think, is increasing the effect of the other, some things like that.
Okay. Thank you. Yeah, I see it's licensed specifically for agitation and aggression in Alzheimer's. So
In the United States.
yeah, something to explore. Thank you for that.
And maybe one final comment from Emma Manuliak, if I may. Do you want to speak to your question or your comment there, and then we'll move on to our case?
I was just, when I worked in long-term care, I found that when staff would say something like that, person screaming, you know, calling out, the physician would come, he would order a medication, but then to get staff to start recording if it helped at all was really hard to get staff to buy in. And once they were started on something, to have it removed was like pulling teeth, not from the physician, but from the staff. Even though it wasn't doing anything, they still they needed that crutch, is what I felt like. And so then you would have a person, like the way I see it is, you have a person who's got like screaming out, and then you add some medication that just kind of blurs the water for them, makes it even, it's not helping them at all. Like, my heart just goes out to them. I just had to say that. I'm sorry.
Yes. Well, often when I work in long-term care, I ask, well, you know, I try to get out of the subjective, well, it's working or it's not working, by having at least some documentation or grid or analysis of, is there a decrease in frequency or severity. And with the question of deprescribing, here in Quebec, we did a project which is now everywhere in the province in long-term care, trying to deprescribe some medication when it is appropriate. And people do that with all the team together, having some caucus, discussing what is the behavior, what is the treatment, did it help? We're trying together to decrease the medication, can we assess? And they have those discussions every week. So they do it together with the objectives, and everyone is able to verbalize, and it helps in order to be able to deprescribe some medication. Of course, families and staff are often very cautious or afraid when there were baseline high aggressiveness or psychosis. So you need to be cautious when you deprescribe those medications. Do it very slowly and reassess if it's coming back. But if there's good communication with everyone and you're able to reassess and do it together, it's better done.
Yeah, the idea of the as they say in Alberta, I think there it is. Yeah, the appropriate use of antipsychotic rounds. We call them huddles, deprescribing huddles, where it's the team that identifies which of the residents may be appropriate, and they can support trying to deprescribe, can be a really nice starting point.
Yeah.
And then I see that Marie-Lise has talked about a nice tool from Behavior Supports Ontario, their version of the Dementia Observation Scale, which is a relatively easy way for folks to be able to quantify whether changes are making a difference or not. David, I see you're responding a little bit. Thank you for the DM